And so we thank you all for joining. And we'll just ask that if you can, if you're not speaking, to please mute so that we can hear our speakers. I'm Sing Pallett, president of CMDA, joined by co-hosts Chris Horton and Leslie Eber today, and our board of directors. This is our monthly meeting for Tuesday, December 3rd. On the screen, you can see our agenda. It's not very long, but we hope to have some really great discussion. And why don't we go ahead and start with our first speaker. Jenny, would you like to go first?
Happily, let me share my screen here.
Thank you so much.
You bet. All
And
right.
we have
How much time would you like me to take, Sing?
5 or 10 minutes. Take your time.
Okay. All right, everybody. I'm Jenny Albertson. I'm the Director of Quality and Regulatory Affairs at the Colorado Healthcare Association. So we represent almost all of the skilled nursing facility beds in the state and about a third of the assisted living beds. And I'm responsible for being our regulatory conscience. And so I'm going to update you a little bit today. So first off, just so you are aware, there has been a release of the 2025 coinsurance premiums for Medicare Parts A and B. I know this pertains to your patients often, and they might have questions and choose to not receive care in certain settings because of the cost and so forth. So be aware that that is out there, and there is a link to a fact sheet there for your reference. This may not be all that important to Metro Denver type individuals, but for our rural providers, the temporary rule extension that the DEA and HHS just allowed for controlled medications is going to be a real relief. So this was set to expire December 31st. These two agencies have to come together to define a permanent rule, and they have not yet done that. So in lieu of cutting everybody off from access for prescription without physical presence with the resident, they went ahead and extended this provision. It's an old provision from COVID days for us to actually proceed with audio video telemedicine encounters, especially significant for opioid use disorder management. So heads up that that is out there and extended in case anyone was concerned about it. A lot of things for our telemedicine have expired. I can speak more to that in the future if there's questions around that. I do get quite a few questions. Updates to the SNF regulations have just come out. Now, this is not effective yet. It will be rolling out February 24th, but I'm going to go over with you some information about medical director particular surveyor guidance that is going to be, it'll impact how you approach, how you manage the docs in your buildings, basically. There are a lot of other takeaways that don't pertain so directly to you, but the majority of it is scrutiny on antipsychotic medication use and overall psychotropic medications. They're tightening that down in terms of surveyor guidance. And they've also consolidated tags under discharge deficiencies. So they eliminated, I believe, 4 deficiencies and put them all into one new deficiency that encapsulates all discharge procedures. So it'd be involuntaries as well as voluntaries and all of the requirements therein. So it's interesting to look at. I'm not going to belabor it here, but just so you know, this is out right now as temporary guidance, but it will be finalized February 24th and expected to be implemented right away. So you should be made aware of it. There will also be some inclusion of social determinants of health in patient assessments, and they want us to start pulling that into our QAPI discussions. So we're talking about like access to meals and transportation if they're discharging from a post-acute stay. That will be actually incorporated into MDS questions moving forward, interestingly. So it'll be kind of an all-encompassing, let's look at a whole person approach for whether this person can actually succeed back in the community or they have true ongoing need for long-term care. It's meant to define those levels of care more specifically. Let's see, there's some tightening down around the transfer and discharge language when they consolidated that into one deficiency, but it's primarily about making sure that we've ensured a safe discharge. That's just a basic rule that we've always wanted to abide by, but now it is delineated a lot more clearly for how surveyors are supposed to investigate it. So the medical director tag, F841, which I'm sure you're all familiar with already, has some additional guidance added. And when I say guidance, so here there's two different things that we're dealing with. There's federal regulations that are actually in the Federal Register. And then is surveyor guidance, which we nicknamed the SOM, the State Operations Manual, for the state surveyors to understand how to go about conducting their duties around each regulation. And it goes really in depth and it cross-references the regulations, and it basically acts as a manual for them while they're in the field. We're talking 900 pages, okay? It is no small potatoes, and they're re-releasing the whole thing because of how many little updates they did throughout. But F841 received several updates, and in the surveyor guidance, when you scan through the memo from CMS, you'll see red line italics. And that's why I put it that way in these slides, so that you can easily scan through and identify. You can also, when you look at that 900-page document, do a magical Control F, which helps you find something with a keyword, and you can look up medical director and scan through all 161 mentions of your glorious role. So if you want to choose to do it yourself, you're welcome to, but I'm hitting the high points and giving this to you in slide format so that you have it. A couple of high points. I'm not going to read this to you. Obviously, you are educated individuals. You do have to take part in developing resident care policies. That's something that they never really got in depth with before. It was kind of assumed that that was part of QAPI. That's now actually described. And they want you also intimately involved in the facility assessment, which should inform your policies and should be based on your acuity and so forth. It's all kind of interwoven. So they've outlined that in detail. I also wanted to have you understand that they want you to not only approve the facility policies when you do your P&P annual review, but you actually have to be part of developing it, because they want you to present to the team what you understand are the residents' physical, mental, and psychosocial needs. And so even though you're part of an IDT that all does that, they want your particular input into that. So as you are doing QAPI meetings, make sure your administrators actually note in the minutes that you've been part of that policy development. They've also given us some examples when they're investigating of how they would cite, and I wanted you to see this as well because it really does help illuminate the oversight role that you have. So they're particularly concerned, like I said, with antipsychotics and schizophrenia diagnoses being erroneously assigned to our patients and our population. And so they've named that as one of the examples here, and I thought it would be helpful for you to see it. Basically, they're saying if a medical director doesn't review the medical records to find out why a new diagnosis of schizophrenia is given, then they've been remiss in their duties. They really do need to dig in when they see a new antipsychotic, and particularly a new diagnosis altogether. The other piece that they've added to our guidance, apart from yours, is that when it comes to antipsychotic use, they want to know that it's more than just a diagnosis that's supporting its use. They want to know, have you actually dug into whether we've tried everything before we've used this psychoactive medication? And there has to be evidence in the record that we've looked at that. So as you're giving your oversight, ask some hard questions around that, because surveyors will definitely be doing so. And I copied out for you some of the critical element pathway that pertains to you and some of the other tags that they would cross-reference with you. And this is just sort of how they guide their process. When they're triggered to look at chemical restraints, for example, they're going to ask, is this person over sedated? Does it look like they weren't sedated before the psychoactive med was in place? Okay, so then does that mean staff are implementing this for convenience? And that term, convenience, is peppered through all of this surveyor guidance. It's very negative in terms of its impression of what we do for caregiving. But that aside, I mean, obviously we agree with not medicating people for staff convenience, so we're not going to fight against that. But at any rate, that's what they're getting at. And then a quick mention here, just for your reference. I know Dr. Oz has been fielded as a potential CMS director, which is going to obviously directly impact what we do every day. So I looked into him just a little bit for his background and how it pertains to what we do, and just mentioned a few things here that might potentially come up if he were put in to head the CMS. And it looks like the main thing that people are worried about is that he's very pro Medicare Advantage, and that's a Trump administration push. Also, they essentially want to privatize Medicare. So basically, what will happen if they decide to push this is they will make it so that the people that qualify for Medicare benefits will actually default to a Medicare Advantage enrollment and have to choose to default out to a primary Medicare. And we all know how difficult it is to get authorizations and ongoing care for people that are on Med Advantage plans. So this could be problematic, but you can see from a fiscally responsible standpoint why people would want this, because obviously Medicare Advantage spends less money than Medicare primary when they're driven off MDS reimbursement. It basically allows the federal government to put in some spending caps without having to cap Medicare spending. So we'll see if this goes through. We'll see if Dr. Oz goes through, but that would substantially decrease lengths of stay for post-acute care. And the evidence is not positive in terms of algorithmic decisions for continuing care in nursing homes or approving it in the first place. Also, they're fielding the option of eliminating customary vaccine approvals through the FDA, which could make vaccine offerings delayed or convoluted in some kind of way. A lot of that is procedural norms and not laws of any sort or regulations. And so a lot of changes could happen at the FDA around vaccination and our approach to that. In fact, they've talked about disbanding APIC altogether. It's really uncertain how public health is going to proceed with this. And then the staffing mandate, it's quite possible will kind of vanish. CMS is likely to be more flexible in terms of regulatory oversight under a Trump administration, I guess. They want to deregulate more than they want to regulate. So that might go away. And then there is the modified survey process that we've been piloting for shortening surveys and trying to create efficiencies in the state survey process that I think will probably get pushed a lot harder because it will cut down on spending through CMS. So, okay. That is everything I had. Thank you.
Thank you for taking the time to prepare that, Jenny. Are there any questions for Jenny?
Jenny, is there anything good coming from these attempts to reduce the red tape that I wanted to see from all the changes that they are suggesting?
Honestly, if you deregulate nursing homes a little bit, we might see a little bit more flexibility and focus on patient care. That's my hope. We shouldn't be quite as heavily handedly overseen as we are. It spends a lot of energy for us away from bedside. I think you all feel that as well. There's just a lot of paperwork and just a need for being rigid in your approach, and it makes you less patient directed, honestly, when you're worried about that. Although the attempt has always been to make patient direction the through line in all the CMS language. It's like micromanagement, right? When you have an employee who is micromanaged, they are much less likely to be creative, to feel empowered, and to feel rewarded in their work. So if you deregulate it at least a little bit, you may see an improvement in staff burnout and all the other things that go with that.
Thank you. And Dr. Reddy was writing in the chat box, making sure that the diagnoses match what's listed on the PASSAR and the level 2s. Do you agree with that, Jenny? And then maybe we can move on to Chad and let you go ahead and comment as well.
Yes, absolutely. And we actually just discussed this with our social services professionals committee. Your social service individuals need to be auditing every admission for PASSAR recommendations, reading the actual recommendations, make sure they're in the care plan, articulated, and all of those recommendations are truly met. And sometimes it means you've bitten off more than you can chew, but you really have no alternative once you've admitted someone that you have to implement all the PASSAR 2 recommendations. So yes, great insight. Thank you.
Chad, why don't you go ahead?
Sure. Can you hear me?
We can hear you.
All right. Success. I would agree with that. I think the biggest concern ends up being, of course, the new diagnoses. And if the person's new to you, that in many respects, it is a new diagnosis. people come from other settings where they may not have had contact with mental health systems, and getting that diagnosis in place and following the guidance around, what is an acceptable source of the diagnoses, I think is going to become a very important part of, has been an important part of, and will continue to be an important part of our future in terms of getting the right justification in place for those, particularly antipsychotic medications. I guess kind of segueing to the conversation, there are two of the most highly regulated industries in the United States: nuclear power and nursing homes. And with the tags that have been eliminated, perhaps now we are solidly in second place. And you would think maybe that might make it a little less complex, but it makes it more complex because we're taking the intent of all of those regulations, and I'm going to use the admission transfer discharge change as an example. We knew some time ago that this was a very distinct possibility. And when we look at the regulations and we're doing our inspections, you could have read through 622 through 626, and a lot of the language looked the same. So it was how do you comply with the regulation, and on the other hand, how does the surveyor identify if indeed noncompliance exists, and where do you ask the facility to address it? I think by having just now 2 tags, and one specific for the inappropriate transfer and discharge, it should make that a little bit easier, but it's going to encompass much more in terms of what we have to look at to determine whether there's compliance with that regulation. I won't get into everything. I'll just say ditto in many respects to what Jenny was talking about. What I've seen in going through the revisions and the changes and whatnot, I've seen a market opportunity for education with our surveyors. This is very complex in terms of how we're going to look at it, and right now, we're uncertain how we're going to approach this. We're going to evaluate what these changes are, what they mean to us, and then we'll proceed. And this has been the case with some of the other things we are faced with, where there is very black and white thinking about compliance with particular regulation, and sometimes that reduces significantly our ability to fully understand the situation and make a compliance decision around that. We hope that we're going to be able to find those opportunities with these changes. The other thing that comes forward is there's a lot of interconnectedness from the, in the changes that are being made that really emphasizes the facility assessment from a fundamental standpoint, and then the involvement of the medical director as really the clinical lead to, care at the facility, and then reinforcing the QAPI process. So there's that opportunity to self-identify and correct potential noncompliance on your own through a good, healthy quality assurance and performance improvement process. So, that's kind of where we are. We're going to put our work in, and once we've done that, we certainly will have more conversations with the community just about how we're going to approach these things. Just as a quick update, we've done a recent round of interviews for nursing home surveyor staff, and recent openings, the openings that we have recently, we may be able to fill those. There's going to be a few positions that we can't fill, but it looks like we're going to get as close to fully staffed as we've been, certainly since the pandemic. We really haven't seen any significant changes to the frequency of the citations that we have. As usual, the more requirements included under a regulation, the higher the the rate of citation. And those examples include infection prevention, sanitary food service, accident hazards, and ADL care for dependent residents. Recent immediate jeopardy situations have included, these are both under accident hazards. There was an immediate jeopardy situation for elopement, as well as an immediate jeopardy situation for entrapment. And in this case, it wasn't the side rail, it was looking at a positioning poles, and there was a lack of assessment as to the safe placement and monitoring of the continued safe placement of those assistive devices. Recently, and I'll just close with this, recently I had the opportunity to talk through some things with Dr. Eber following a survey. And I think we were able to come to some conclusions and found some common ground. And I know that, for the most part, I think this common ground exists. And so what I would offer is that if during the course of survey, you find that there are questions that need to be answered, and my first inclination is to have you talk to the team coordinator on site. But if we're not able to kind of solve things there, it's good to get myself involved while the team's in the field, because a lot of times what comes down to is miscommunication or misunderstanding that has taken place, and we're kind of giving that a life of its own. But in my conversation with Dr. Eber, I think we were able to recognize that we should all assume positive intent from each other. We did recognize that we collaborate for the same compliant resident care. While we've got different roles, we're all interested in the same thing. We certainly support more person-centered care. And I think the last thing that we agreed on is it costs nothing to be kind. And I think with that approach and looking to work out things while the team's on site in a way that minimizes any sort of incongruence, perhaps, and we're not always obviously going to agree on everything. But I think that we can work through these things, knowing that, with all of these changes that we're being faced with, we're going to do everything that we can to provide as much information and clarity, transparency as to how we're going to approach that, so that, like I said, it deregulating, whatever that might mean, it's really about getting that care. And then we're both a part of that process. So I'll leave you with that, unless there are any questions.
Can you just tell us a little more about the elopement circumstance, why it warranted an IJ?
Yeah. So you have an event that might happen that may result in serious harm, serious injury, that could have been preventable. There were approaches, interventions that were in place that the facility failed to implement, which allowed the person to elope. A good example of that sometimes is the reliance on a water prevention system, and then not checking the water prevention system so that it remains ineffective. And I think if I recall correctly, the facility identified the concern, put some corrections in place, but at the time of the survey, the corrections were not in effect, meaning the alarm system that the facility relied on was inoperable during several observations. And then there was another situation where the alarm sounded, but nobody responded. So it's that, did something happen? Yes. Was it fixed? the plan was there, but then is it likely to occur? Is the serious harm likely to occur? And in the situation where these interventions are not implemented, we can say that it is likely to occur. Did that help?
Yeah, thank you.
Thanks for providing that example. And Chad, do the surveyor teams have a preference for how they wish to be introduced or to meet the providers or medical directors who might want to engage in that discussion?
I think the sooner the better in the survey process. However, because of the way that the survey goes, meeting the medical director at the end of the first day, and if that's the only opportunity to communicate with the medical director, just because of the way the survey process is laid out, we're not going to be ready to ask meaningful questions at the end of the first day, beginning of the second day. We're still going through our kind of discovery, if you will, our initial stages of the survey. It's having those meaningful conversations as soon as possible, but once we get into the investigative portion of the survey. So that's usually around day 3. But as always, it helps, and we should be asking those questions because we're not physicians. We don't have that intimate knowledge that the physician may have of the clinical care practices at the facility or of the clinical care needs of the resident. But we should have that understanding of the regulations of the regulatory process. So hopefully we can, have those questions answered. Help me understand, because that's really what we should be looking for.
Appreciate that. Thank you. Well, why don't we go on to our clinical presentation about vitamin D? We have a great presentation prepared called A Dose of Sunshine, Vitamin D Supplementation in Post-Acute and Long-Term Care Residents. Emily Losinski is a 4th-year pharmacy student at the University of Colorado, Skaggs School of Pharmacy, and she is currently on a 6-week rotation for post-acute long-term care with Dr. Jennifer Connelly, and she'll graduate in May of 2025 with her doctorate of pharmacy. And Dr. Jen Connelly received her doctorate of pharmacy from the University of Colorado and has board certification in geriatric and ambulatory care pharmacy. She is the pharmacy director with Continued Care Pharmacy and Rocky Mountain Senior Care, and she has been a member of CMDA and presented for us for several years. So go ahead and take it away.
Alrighty, thank you. I'll go ahead and share my screen here. Alrighty. Thank you for the wonderful introduction. So as introduced, my name is Emily, and I'm presenting here with Jen, and we're here to give you your dose of sunshine for the day. And we're talking about vitamin D supplementation, specifically in post-acute and long-term care residents. So as we talk about today, we're just going to give you a reminder about where you find vitamin D and just the commercial preparations, as well as the biological functions that we know, but also biological functions that are often cited, but just provide some more information there. We'll provide some laboratory assessment, some dosing assessment, and just provide some background on some of the toxicities, updated guidelines, and clinical pearls specific to the post-acute and long-term care setting. We know that this is definitely a topic where there's a lot of information out there, but not necessarily a lot of answers. So our goal with this presentation here is to provide you our perspective as more of that pharmacist side, provide some of the information and try to apply it specifically to this setting of the post-acute and long-term care. So by the time we get to the end, I'd be happy to answer any questions as we get to that point. So firstly, vitamin D is a fat-soluble vitamin, but interestingly enough, technically vitamin D is not a vitamin. By true definition, a vitamin is something that your body cannot produce endogenously at all. But we know that a lot of our vitamin D that we get is either through sun exposure or even through absorption through dietary means. And so that's just kind of an interesting little fact about vitamin D. And oftentimes that we find that vitamin D comes in two main forms, vitamin D3, which is cholecalciferol, and vitamin D2, which is ergocalciferol. The main difference there is that vitamin D3 is the vitamin D that is produced after sun exposure. And if you get it through dietary means, that's mostly coming through fish and meat sources, whereas vitamin D2 is more found in plant-based sources if you get it through dietary means. Of note, however, both require hepatic and renal conversion to the 25-hydroxy vitamin D, regardless of how you absorb it or synthesize it through the sun exposure. These are the two main forms that vitamin D supplementation come in, so we'll find that both vitamin D3 and D2 are commercial products as well. This just highlights dietary examples of vitamin D, and this is just really showing the main sources that vitamin D can come in. But this also really highlights why patients might need supplementation from vitamin D. Not only are these uncommon sources as far as dietary means go for just the general US population and probably the long-term care population in general, it also highlights that there isn't a lot of vitamin D per se in these foods. We know that one of our main sources is we can fortify our dairy with vitamin D, but you're getting less than 100 units of vitamin D with that, and that's if you're getting like the proper serving. So this just highlights why we have to consider vitamin D supplementation, because it's not exactly unknown that we don't get enough potentially through our diet. This highlights the commercial preparations that we find out there in the world. So it comes in vitamin D3 and vitamin D2 as the two main sources that we'll most likely see. Some of the main differences there are highlighted and discussed, but you'll see that our vitamin D3 is an over-the-counter capsule that is most commonly found, and this comes in a variety of different strengths. So there's a couple noted there. And vitamin D2 is our prescription strength capsule. It comes in that high dose 50,000 units. And of note, vitamin D3 is known to be more bioactive, whereas vitamin D2 is a little bit less bioactive. And so that kind of comes into play with our decision making and our dosing. So some of the biological functions or potential benefits of vitamin D that are cited, there are a variety. And as you'll see in this graphic here, there's some things that we find that we have been known to be a benefit of vitamin D. And then there's some things that we have saying, hey, we've done a lot of the studies. We're not exactly sure if this is quite the right route. But this graphic just kind of highlights where we might see some of those. Maybe it helps, but it's not necessarily a true cause of vitamin D. And also it helps provide where our patients or patients' families might say, hey, I heard vitamin D does this. Can you answer this question for me about it? So it's just good to know what is out there, regardless of what the studies might say, just because we know that patients might come in with those questions as well. But some of the main biological functions that we know that vitamin D does contribute to is helping maintain normal blood levels of calcium and phosphorus, because vitamin D is pretty key in the absorption of calcium and helping to maintain strong bones and promoting that bone mineralization. Of note, one area that is trying to be expanded on with vitamin D is this role in innate immunity. So vitamin D has been found to really play a role with toll-like receptors of a lot of our cells in our body, and particularly when it comes to viral infections. So when we say enhances the immune system, this is something that is being explored currently, but I don't think that we have a lot of very good answers about it yet, but just something to think about in the future. And then of note, vitamin D insufficiency does lead to releases of that parathyroid hormone, so that can cause bone resorption problems, as well as the increased risk of fractures if a patient were to fall. And these can be things that we need to think about in our geriatric population and potentially our long-term care population as well, as a variety of these patients tend to be on the older side. And then there's even things like kidney function we have to think about. So it's important to determine what their vitamin D efficiency looks like. How we might assess for sufficiency versus deficiency of vitamin D, there is a lot of different citations out there of what counts as sufficient or deficient. But overall, what seems like to be the general practice here is that in our general population, adult population, sufficient vitamin D levels are anything above 20 if you have no CKD, but if you're a CKD patient, we do target those higher goals. And of note, we often find that in our geriatric population and even our long-term care population, we do like to target a little bit higher goals of that 40 to 50 range for sufficiency. And basically determining if you are sufficient or deficient in vitamin D really tells us the therapy plan and if we want to go more of a maintenance therapy approach or we have to replete someone's vitamin D. Also, when it comes to determining whether or not you need to assess someone's vitamin D levels with laboratory results, there's also varying recommendations out there about how to go about that. And often you'll find that vitamin D routine screening is often not usually recommended. And this is applied to the general population, and there's a variety of reasons there. One can just be it can be costly. But also, it's really not needed unless you have suspicion for a patient to not be sufficient after repletion, or if you have other indications that might mean that you might want to check vitamin D levels more regularly. And that goes for the general population. It's often considered to be done more regularly in the institutional settings. So, like our long-term care settings, we probably are going to be checking up on our patients a little bit more about it for a variety of reasons. One, we do have those higher targets for our sufficiency, so we want to make sure that we maintain that in our population, as well as these patients might have a variety of more extensive comorbidities associated with them. So again, just kind of treating the patient as a whole, we just want to make sure that all those bases are covered. So we might just check up on them a little bit more than someone who doesn't reside in a facility. Alluding to our dosing strategies for our patients who are either sufficient or deficient in vitamin D. This table highlights what I think a lot of people are familiar with vitamin D dosing, and that goes with if you're deficient, treat them with high dose vitamin D, then shift over to maintenance therapy. And if they are sufficient with their vitamin D levels, we do a maintenance therapy. So this is an example of those dosing strategies. And again, here, this is what a lot of people are familiar with. This is where a lot of things are cited, but also it's important to note that this might be something that we consider more in the general population. And so while this is good to be familiar with, as we kind of tie in the new guidelines and try to apply these clinical pearls to the long-term care setting, we'll discuss a little bit about how we might have different strategies, particularly in this population. So we know that there's going to be a lot of questions about dosing, but we will address those, don't worry. One thing too with vitamin D that must be noted is that it has to be given with a high-fat meal for appropriate absorption. And this is particularly important for maintenance dosing. So with maintenance dosing, if you're doing the standard cholecalciferol 1,000 units daily and you're not giving it with a high-fat meal, the absorption can be as poor as basically not taking vitamin D at all. So it's important to consider that as a piece because this might be a population where they just have lower dietary intakes in general or restrictions on what they can eat. So that's really going to impact what we'll discuss a little bit later on about addressing maintenance dosing in this population. Vitamin D toxicity can occur, but it usually begins to be seen at doses of about 40,000 units daily. To put that into perspective, the vitamin D3 cholecalciferol, it's mostly known that that's about 1,000 units daily. And then the 50,000 units of the ergocalciferol once weekly is equivalent to about 7,100 units daily. So we're not really approaching those doses that we tend to see toxicity. However, if for whatever reason you do start to see that or you are concerned about that, via vitamin D levels in a lab at all, what you might see is nausea, vomiting, poor appetite, constipation, weakness, weight loss. Elevated calcium in the blood can also occur, and that can cause altered mental status changes or even heart arrhythmias. And then the worst case scenarios that can cause is calcium phosphorus deposition into soft tissues. And that can be concerning if it happens in something like the kidneys. Where this might be relevant is that a lot of cases of vitamin D toxicity happen with over-the-counter preparations, and that usually just goes with mislabeling of vitamin D. And so oftentimes what happens is it just is important that as a facility, if you are using over-the-counter vitamin D, to make sure that you're choosing from a brand that is USP certified to make sure that it is going to be as closely accurate to the label as possible. And this is another reason why we might see more use of the ergocalciferol since it's a prescription product. So because of that, with the more regulation, it's more guaranteed that you're getting that true 50,000 units daily and not any more or less. This is a statement from the updated guidelines from the Journal of the Clinical Endocrinology and Metabolism. And so they provide a variety of recommendations across all populations. And the one statement that applies most here to this population is within the general population, those aged 75 years and older, they suggest empiric vitamin D supplementation because of the potential to lower the risk of mortality. And so what they are doing there is they're speaking generally about the population, and this is the population who doesn't live in institutional settings. So we are taking this statement and having to apply it to our post-acute and long-term care. And basically what they cite here with this potential risk to lower mortality is while vitamin D doesn't necessarily prevent falls per se, we know that falls can be a significant concern among the geriatric population and especially among our long-term care population. So basically they cite that staying replete with vitamin D, they found that yes, it didn't prevent falls, but if a person were to fall, your risk of fractures can be lower. And this is because there are an estimated 9 million fall injuries in adults 65 years and older alone just in the US, and that can be really costly. It can cost up to 50 billion annually with those fall injuries. And that's from a variety of things of having to treat patients, but also that means patients are having to leave facilities to be hospitalized. And we know that falls are associated with just high morbidity and mortality in this population anyway. Of note, again, just alluding to, there's a lot of interest in trying to determine what vitamin D's role is in immunity, so respiratory illnesses. That's just another area where there's a lot of morbidity associated with it. And so those are the things of, yes, it's maybe not preventing, but being sufficient in your micronutrients that you just have better outcomes in general. So that's why they empirically recommend it. Of note, there are some limitations to the clinical trials, and this is where a lot of the discussion of, hey, I heard this or I heard this comes in with vitamin D. So when it comes together in the guidelines, there's two things we have to consider. One, just the limitations of them in general, but also these are studies that are done in the general population. So not only is there variation there, but we also have to take into consideration how that recommendation transfers over to our post-acute and long-term care population. So some of those limitations that we think about when we try to apply these guidelines, the first one comes in the emphasis of taking vitamin D with a high-fat meal was not outlined in a lot of these trials and maybe wasn't even done. And so there's variations that might cause different recommendations, especially as we apply it over to our post-acute long-term care setting. Also, there's a variety of dosing schedules that are limited to basically different populations, and there's really no set standard. So we kind of know the general standard is if you're vitamin D deficient, replete, go to maintenance therapy. That's where we all kind of agree on, but how to approach maintenance therapy, there are some discrepancies for sure. And from the pharmacy perspective, we'll discuss a little bit about why we might have different recommendations in this setting versus the general population in a second. And then average vitamin D levels are considered adequate at about that 30-31 nanograms per milliliter, but there really isn't specific vitamin D levels that are agreed upon in a lot of settings. And so that's where there's a lot of variety in the differences between, oh, I heard this was replete or I heard this was replete. And so taking that into consideration, assessing the populations and the guidelines, and really looking at the specific population of the long-term care setting, that our goal of about 40 to 50 is specific to this population here for all the reasons that we've discussed so far. So wrapping it up and applying our recommendations into our clinical pearls specifically for this post-acute long-term care settings, there's a couple things to think about. Even though the body endogenously makes vitamin D or produces and absorbs vitamin D, we know that we often don't get enough sun exposure or dietary intake, and so that's why it's not a surprise that we often need to supplement vitamin D and that it's something to look for. So basically, as the patient comes in or at the facility, it's just good to do due diligence and really assess if what they might need for vitamin D. Sufficient vitamin D levels contribute to lower mortality overall in this population. In the general population of 75 years or older, that was something that was cited by the guidelines, and they have a lot of their reasons why that we discussed. And then applying that here, we know that we're dealing with our post-acute long-term care population, much of which is existing in this higher, older geriatric population. So just some of those things that we want to think about for our general population, we also want to apply here. And then one thing in particular that is going to be different from our general population is once someone is sufficient in vitamin D, so if you test them and you replete their vitamin D levels with the treatment dosing, our recommended maintenance dosing that can be considered at a facility is the ergocalciferol or the D2, 50,000 units once monthly with a high-fat meal. And this is preferred in this setting for a variety of reasons or can be considered to be preferred in this setting. One thing is from the patient perspective, it can just help limit pill burden. We want to make sure that they are replete, but we also know that there's just high comorbidities associated with these patients. And so it's just kind of our due diligence on that end. It can also help with things with med pass burden. So if a facility has a high acuity, not a lot of staffing, that is something that can be considered on like a facility to facility basis. Also, this is again the area where we're talking about there's a variety of over-the-counter products, and oftentimes what we see in the charts as a pharmacist side from chart review is patients are getting maintenance vitamin D, but it's not consistent even at the facility level of what patients are getting. Some patients are getting as low as 200 units per day, and some patients are getting as high as 5,000 units per day. So maybe having a plan on a facility-wise of what to do for maintenance therapy, this sort of, hey, we know that we do this 50,000 units once monthly once they are at maintenance therapy. It's just a way to maintain synchronicity across your facility. And then again, you don't have to worry about, oh, what over-the-counter product do we get? We want to make sure it's the right amount of vitamin D. And then just from another patient perspective, again, these are patients who might have low dietary intakes to begin with, and then even have limitations about what they can eat anyway with that. And so if we have to give vitamin D with a meal, it might be difficult for patients to get a high fat meal in the morning and have it be enough at that maintenance 1,000 units daily. And what we discussed is that at that dose, if you don't take it with the appropriate dietary adjustments, then you might not be getting vitamin D at all. So this is just one way to maybe ensure that they are getting that little boost of maintenance dosing in general. And then lastly, we talked about how routine monitoring is not usually done in the general elderly population, but we probably will consider it and often see it done in our post-acute long-term care population. So that's something that we'll see there. So that wraps up your dose of sunshine for today. Jen and I are happy to answer any questions. We know that some of these slides were sent out before, but they will be sent out again with some minor tweaks and updates. And one of those updates will be there are some citations in the notes section of the PowerPoint. So as we discussed, if you are interested in those citations there, if you download the PowerPoint, you'll see them there, just as a note as we get into our discussion. We are happy to answer any questions that you might have. I see some notes in the chat, so I'll pop that open.
Thank you, Emily. That was great.
Really appreciate it. It occurs to me this is our second month in a row where we've had a graduate student prepare a presentation to educate us. Thank you so much for taking the time to do that. I know it's a really big topic, and we do have a lot of questions. So Dr. Chris Horton and I will be happy to field questions and direct them to you. We have some in the chat box even. I wonder if I could start with a question that I had when I was listening to the presentation. I think I've seen the cholecalciferol vitamin D3 in a 50,000 international unit tab form. And if that's the case, do you have would you change the recommendation for maintenance dosing if you have access to that tablet?
From my perspective, and Jen can jump in as well, as far as that maintenance dosing, some of those considerations on doing that kind of once monthly sort of dosing, I would say that if you do have access to that vitamin D3 50,000 units once monthly tablet, that would be an option. I'm not sure if I've seen that as a prescription product. One thing to think about too is just going to that vitamin D toxicity, since we know that D3 is more bioactive, just making sure you get that USP certification on there, because at vitamin D3 at that high, you could be at risk of potentially having mislabeled vitamin D and just getting too much. So just something to consider if you decide to go that approach with your vitamin D.
I agree. I would choose the prescription strength, the prescription version, just to have that standardization in the dosing. I think that's really important, especially if we don't go back and check those levels frequently enough. We need to make sure that we know how much we're giving our residents.
So there's quite a few comments and questions, so I'm trying to get through these. There's one comment that vitamin D has not been shown to decrease the risk of dementia or cancer. There's another comment: daily dosing is recommended due to adverse effects with intermittent dosing as per the new guidelines, which have been submitted. There's a link to reach the New England Journal of Medicine Journal Watch guidelines. There is a specific question: why use 1,000 daily for D3 rather than 50,000 units Q 14 days or Q month, one less pill to take each day? More adverse effects question. And then the follow-ups: why use D2 at 50,000 instead of D3 at 50,000?
Mhm. Yeah, I'll talk about the comment about vitamin D not being shown to decrease certain things, and that is true. And so this slide here, it is kind of tricky when you talk about the biological functions and like these potential benefits of vitamin D. So this graphic here, there are some things that we know that vitamin D is like, yes, it's not going to do that. So that kind of cognition and the cancer side, the cancer benefits as well. And so this kind of highlights things that are kind of out there in the general population. And as I was mentioning, patients, either themselves or family members, might come in and have questions about their family members or friends' medication, and just say, hey, I've heard this about vitamin D. So kind of this left side of the slide here is what we know more objectively, or what is trying to be assessed objectively with the innate immunity part. And this right side of the graphic here is something that you might see out in the literature, because there is literature out there that tried to assess this. So it's kind of like information that still floats out in the void that you have to sift through. But it's also good to know, because if you know what a patient might bring to you, then you know that you can, what answer you can provide. So we know that there's definitely a lot of differences in discussion there. As far as the dosing for kind of the 50,000 of D2 versus D3, that's something that we talked a little bit about with just like the prescription version. And then our recommendation of the D2 50,000 once monthly, again, is just for some of those things of just like the med pass burden or pill burden in general. But if a facility decides that the 50,000 of the D3 every 14 days is how they would like to approach maintenance therapy too, I have seen the literature that that is also appropriate. Anything to add, Jen?
No,
About the potential harms of that intermittent dosing versus daily dosing?
Yeah, so there is a variety of studies. So when you look at the meta-analysis and what the guidelines were using, they were citing that there is the majority of the studies that are citing that there really isn't harm, but then there are some studies where they did find potential harm, and most of the harm associated with vitamin D does come down to falls or fractures. And ultimately what is happening is that they're finding potential increased risk of falls, and that's the harm. But when they are looking at why patients were falling, it wasn't necessarily because of the vitamin D. There were just things where also among taking vitamin D, whether or not how much the patient was feeling better, or how much they were encouraged to ambulate. Sometimes some of this encouraged ambulation for patients, then they then had falls. And it was like, well, the patient was falling not because of the vitamin D, they were falling because they were encouraged to ambulate and move around. And so this increase in harm, that was the harm they were seeing. It wasn't really due to some of those things that we were seeing with the toxicity. So I don't think that higher doses necessarily mean increased risk per se, but that's, again, you just have to make sure that you educate your patients about good fall behaviors, and then also why we might consider more frequent monitoring in this population, just to make sure that we aren't bumping them up too high into vitamin D levels.
Hopefully, Perry, that answers your question as well.
Mhm.
And in your reading, did you see differences between, what are the benefits of having an adequate vitamin D level versus the actual effects of providing the supplementation? And
Mhm.
is that a different kind of benefit we need to think about when we're looking at potentially replacing vitamin D?
Yeah, so with vitamin D, I see the chat that also popped up of giving it with some calcium once replete. That is also an option as well. What it looks like happens too with being replete with vitamin D and sufficient in vitamin D level, oftentimes what is happening is that if a patient is on no other medication that promotes bone resorption, what often happens is that being sufficient in vitamin D level at least maintains their bone mineral density. So while it might not increase or contribute to bone remineralization at all, it can help prevent any further bone loss, because they're just maintaining that repletion and their body is not having to have bone resorption occur to have any sort of thing like that happen. And so that's kind of where I think the benefit of maintaining that vitamin D sufficiency is mostly just because we know that there is high morbidity with a fall. So if you can prevent the things that happen if a patient falls by maintaining this vitamin D repletion, I think that's where you get the most benefit. What else can we
There is
answer for you
another
all?
comment in the comments. Someone is usually use a calcium plus D product that's 600/400 BID to meet calcium and vitamin D supplement needs once replete.
Mhm. Yeah.
So
I will kind of throw this to Jen as well, because vitamin D is needed for that calcium component. And so maybe this is something too that if we look at specifically if our patient, I mean, once you are reaching a certain age, we just kind of expect a little bit of that osteopenia in a way, but maybe there's something that we can look into to determine if a patient would qualify for a calcium-based vitamin D maintenance therapy versus just vitamin D by itself. Just because while things are good to replete, we also kind of want to toe that line of not trying to replete everything all at once, but we do know that vitamin D is an important component. So this is kind of the one that we're focusing on. So I don't know if Jen would have some advice on that.
Yeah, we don't usually use the calcium plus D product. I don't see in a lot of our chart reviews and most of our nursing care facilities, we use the vitamin D supplementation. In the studies, I think one thing that they didn't extrapolate very well is that most of the benefit was seen from people who were very, very deficient and replaced. So the majority of the results were seen from people who had a long ways to go versus people who were sufficient per se in vitamin D and didn't see as much benefit. So it's hard to see where that line is. And then again, those studies were largely for population that is not ours and the general adult population and elderly population that is not long-term care. So it's hard to extrapolate that over to our post-acute and long-term care facilities. And really D3 is where it is seen to be the biggest benefit for our population. D2, not the calcium proponent.
thanks. There's another comment. Dr. Beware of calcitrol and vitamin D2 or D3 supplementation.
Yes.
Chris, this is Lee Annenberg. I put that in there. Several cases I've run into over the years of significant hypercalcemia levels, 12, 13, and 14 range from prescribers who did not realize that calcitriol was the active 1,25 dihydroxy form, and then we're also supplementing with D3 or D2. And so several cases required cessation of all the vitamin D supplements and waiting for the hypercalcemia to resolve. None of them required active treatment like saline and furosemide and things like that. But I think it was more an issue that the prescribers just weren't aware that these were similar products with overlapping side effects.
That is true. We've seen that several times in the nursing homes and our monthly reviews.
And what were the markers then of those interactions? Was it the calcium just getting higher and higher, or were you measuring?
Yeah, the patient became difficult to arouse and somnolent, and through then a metabolic workup, looking for blood sugars and creatinines, and happened to notice, oh, the calcium's 14. Well, I wonder why that is. And so then they started thinking about hyperparathyroidism without having looked at the med list, and didn't realize that they were both vitamin D products. So that's just my experience a couple times.
It happens more frequently than not.
I think Dr. Weaver asked the question there. I guess that's what I was thinking as well. It's better worded though. So do you think vitamin D is the benefit, or is it a marker for better nutrition for our patients?
I think from my perspective, it would be more of the benefit. I think even in the general population, a patient who has quote unquote good nutrition, whether that's intake or what they eat, I don't really know if that tells you if they're getting enough vitamin D unless you get that lab level. Because as we're talking about, yes, you do get it through sun exposure, you can absorb it through diet, but it's not found in high amounts in commonly eaten foods. And so I think that even if you have a resident who might have better dietary intake or ability to get foods, I don't think you're really going to see better vitamin D levels per se, even if they have better nutrition. So I think that's where that supplementation piece comes in. And then as far as the cost barrier for vitamin D2, the RX version is like pretty cost effective. So that's part of the reason why it's in the recommendation and often seen as far as our treatment dosing, because it's been known to be cost effective in amongst the studies.
Well, I appreciate all the discussion, and thank you very much for leading our conversation today about vitamin D.
Mm-hmm.
For joining our meeting, everyone, today for our monthly meeting. And we appreciate all of our speakers. We will be meeting again in the first week of January, but not on the usual date because of January, because of the new year. So watch for that in your email box. And we wish you happy holidays upcoming. We'll stay in touch. Thank you.